This is the first of 3 webinars in our Genomics in Practice series. This is a case-based series that will be presented by Dr. Audeh and Dr. Alberty, and they're going to review the latest MammaPrint and BluePrint data, clinical utility, and case studies focused on improving outcomes for Black women with ER-positive early-stage breast cancer. A brief introduction here about Dr. Audeh and Dr. Alberty. Dr. Audeh is the Chief Medical Officer at Agendia, and he's a medical oncologist specializing in breast cancer with nearly 30 years of experience as a clinician and researcher at Cedars-Sinai Cancer Center in LA. Prior to joining Agendia, and in addition to his clinical practice, he served as the former director of the Cedars-Sinai Cancer Center and medical director of the Wasserman Breast Cancer Risk Reduction Program. He's also been principal investigator on a wide variety of national and international clinical and translational studies, and has authored numerous publications in the field of breast cancer, cancer genomics, and targeted cancer therapy. Dr. Jaime Alberty is a board-certified general surgeon with fellowship training in breast surgical oncology. He is the director of the Comprehensive Breast Center and director of the Division of Breast Surgery, Department of Surgery at Kings County Hospital, which is a 639-bed municipal hospital serving a highly ethnical, diverse background in Brooklyn, New York, where upwards of 94% of patients self-identify as Black, African American, or Afro-Caribbean. And he's also the clinical assistant professor of surgery at SUNY Downstate Health Sciences Center. And his expertise includes all areas of benign and malignant breast disorders with a special focus on breast cancer. So I'll hand it over to Dr. Audeh.
All right. Well, thank you very much for the introduction, Karen. Thank you all for joining us this afternoon on the first of 3 of these case-based webinars. The overarching topic, genomics in practice, with in each of these webinars at least one high-risk early-stage breast cancer, estrogen receptor positive, with a case-based approach. As you heard, I am joined today by Dr. Jaime Alberty from Kings County Hospital. And I'm going to begin, of course, by reminding you that today's webinar, as you heard from Karen, is focused on using genomics to improve outcomes for Black women with estrogen receptor positive breast cancer. And to lead into our discussion, I wanted to set the stage with the 2 genomic assays that we will be discussing, which provide comprehensive gene expression profiling in early stage breast cancer. The MammaPrint assay, which predicts the likelihood of distant recurrence primarily within the first 5 years since diagnosis, where the report will separate tumors as being either low risk or high risk in the positive or negative range of the index. And we go on further to classify MammaPrint into 2 categories of low risk, low and ultra low, which are primarily helpful for endocrine therapy management, as well as high risk, which also predicts responsiveness to various therapies. In addition to MammaPrint, we also provide the BluePrint assay, 80 genes as opposed to the 70 in MammaPrint, 80 genes in BluePrint with which assess a different aspect of breast cancer biology, the signaling pathways downstream from the receptors, estrogen receptor, HER2 type, and then of course those without receptor-driven tumors, basal type breast cancer. And in this discussion of hormone-positive breast cancer, with MammaPrint and BluePrint, we are able to identify 5 distinct genomically defined subtypes of hormone-positive HER2-negative breast cancer, each with separate clinical and therapeutic implications. So with that in mind, I will hand over the first case discussion to my esteemed colleague, Dr. Alberty, who is joining us in voice only today, but we will see him in future webinars. Dr. Alberty, go ahead.
Can you hear me okay?
Yes.
Okay, perfect. I'm going to turn off and on my camera once more, just in case. Can't see me? I guess not. Okay. So thank you, Dr. Audeh, and thank you, Karen, for the introduction. I did want to give a little background on myself, and I know Karen sort of went a little bit through this already, but obviously I am, not a Black female, but I do serve that population. And so in 2020, I joined Kings County Hospital, which is one of the 11 hospitals in New York City, part of the New York City Health and Hospital Systems, in the East Flatbush part of Brooklyn, which serves a population that self-identifies in the immense majority, upwards of 94%, as either Black, African American, or Afro-Caribbean. And so the immense majority of my patients are part of this ethnicity. And so we thought we would highlight one of these cases. This is a case of a patient that I saw last year, a 43-year-old Haitian female, and that means she is originally from Haiti, born in Haiti, and then had moved to the US. And so she presented with a painful mass in her breast for 4 months prior to me seeing her. She is premenopausal. She had 4 pregnancies with 3 kids, and the previous birth had been over 10 years ago. There was no family history of breast or ovarian cancer or other cancers in her family. And so the diagnostic imaging, like you can see here on the right side, this is an ultrasound of the mass that was identified at the site of focal pain. It was a mass that was in the left breast in the upper outer quadrant at the 2 o'clock axis, 10 centimeters from the nipple, sort of towards the axillary tail, measuring 3.0 centimeters on ultrasound. She underwent an image-guided biopsy that yielded an invasive ductal carcinoma of high grade or grade 3. And she did have one axillary lymph node, at least one axillary lymph node that looked abnormal in imaging. And this was biopsied as well, proving to have metastatic cancer as well. The receptors obviously were performed at the time of core biopsy. And as you can see from the slide, it was sort of an unusual combination of ER positivity at only 60%, PR positivity at 5%, and HER2/neu was negative at 0. Next slide.
So thank you for introducing that patient case. And I wanted to just kind of summarize what you just told us. 43-year-old woman with ER and PR positive HER2 negative breast cancer, diagnosed on core biopsy with also a biopsy positive node. Again, no family history, and you explained that there were no other cancers in the family. A woman of Afro-Caribbean descent who also had an extensive pregnancy history, but not within the last 10 years, so she would not be considered a postpartum breast cancer case. Any comorbidities in this young woman, Dr. Alberty?
Not really. She was a healthy woman who just happened to have felt something, but she was not on any medications, wasn't on any anticoagulation, wasn't, there was nothing weird about her case.
Okay. So in terms of the next step in management, of course, the decision would be to take her directly to surgery or to consider neoadjuvant therapy in a hormone-positive patient. What additional information would be helpful now, and how did you take your next step?
Yeah, so obviously as a surgeon, we usually are the first, provider to see these patients after they've done their imaging. And so you're sort of faced with the decision of, should we go directly to surgery, or should we consider something else obviously being some form of preoperative therapy. In this particular case, something sort of wasn't adding up for me. This mass sort of grew very quickly in just a couple months. And in addition to that, obviously the receptor profile was sort of not the slam dunk, strongly ER positive, strongly PR positive that we usually see with luminal tumors. And so I said, we should probably look at the genomics of this tumor just to sort of understand what's happening here, because this sort of seemed like there may be a little bit something more going on behind the scenes. And so we did send the MammaPrint and BluePrint on the core biopsy.
And here's the result. You want to walk us through it?
Yeah, so this is, as a surgical provider, this is what we get, the result we get from Magendia when we send the MammaPrint and the BluePrint. You can see my name there. You can see the requisition. This is an ER positive patient, PR positive, and HER2 negative, like we discussed. But, you know, surprise, surprise, we're seeing that in spite of the ER positivity, this is a tumor that is reading genomically as a basal type with a MammaPrint index of the highest capacity, right? -1 is the highest that we can get. And so clearly this is a tumor that is behaving not necessarily like an ER positive tumor, but there's something else going on here. And genomically, we're seeing that this is a basal type of tumor.
And the report, of course, provides some background information from previous studies that have been done regarding the likelihood of a pathologic complete response that based upon what was observed in prior studies. Can you comment on what this means to you as far as the next step in management?
So again, you know, as surgeons, we're always faced with the decision of should we go to surgery first, or should we, you know, try and downstage the cancer, whether it's in the breast or in the axilla, via some form of treatment, whether it's chemotherapy or endocrine therapy. By me seeing this report as an ER positive basal with a probability of PCR 34% with neoadjuvant chemotherapy, that lets me know that if we consider that route, then the patient may benefit from less extensive surgery. And obviously, we all know about the benefits of obtaining a PCR. And so obviously, by looking at this number, 34% goes in line with what we know, the data that's out there for true basal or triple negative cancers. And so in this case, it was sort of a very easy decision to refer this patient out to medical oncology to have them consider her for neoadjuvant chemotherapy.
So as you pointed out, the MammaPrint result came back really at the upper limits of the high risk range. Actually, she falls into that high 2 section that you can see there on the far left of the box. And in the blueprint analysis, she's genomically basal, as you described. So let me provide some of the background data that is not only provided in the summary interpretation of the genomic results, but also I think supports the observation of high chemosensitivity. So the data I'm showing you are from a study referred to as NBreast, a neoadjuvant trial of nearly 1,100 patients that was conducted approximately 1 decade ago. These were patients who were clinically appropriate for neoadjuvant chemotherapy. Over 600 of these patients were hormone positive and HER2 negative. And the nature of the study was that these women underwent diagnostic core needle biopsy. Immunohistochemistry, of course, was performed as standard of care, and neoadjuvant therapy determined. That same core biopsy sample, however, was also analyzed with MammaPrint and BluePrint, and the tumors were also categorized genomically. The point of the study, at least at one level, was to determine whether the likelihood of pathologic complete response could be predicted by IHC versus the genomic categorization. So the rate of pathologic complete response in this group that was identified by immunohistochemistry was overall 10%. But as you can see from the Sankey diagram, as we further stratify these patients with MammaPrint and BluePrint based upon gene expression, we see that a proportion of them are luminal A, MammaPrint low risk, and luminal with intact hormonal signaling, with a very low likelihood of achieving a PCR with neoadjuvant chemotherapy. Not a very chemoresponsive tumor. A large proportion were luminal B, which is MammaPrint high risk, and BluePrint luminal, with a range actually of likely PCR based upon more recent data, which we will review in a subsequent webinar. Most importantly for this case, however, there's also a proportion that you can see of those ER-positive patients who are found to be genomically basal by BluePrint with, as you know, a significantly higher rate of pathologic complete response. And in other cohorts of high-risk MammaPrint patients that are hormone receptor positive, we've identified as many as 28% to be in this basal category. Now, one question that always arises is whether these are the the very low ER-positive tumors. And as you can see from this particular patient, that is not the case. She was 60% positive for estrogen receptor. The actual spread from this study of the estrogen receptor positivity is shown here on the left, where while certainly for hormone-positive basal breast cancers of this type, there is a clustering of the estrogen receptor IHC expression level down in the lower range, you can see that these can range all the way up to nearly 100%, meaning that there is no level of estrogen receptor that rules out the possibility that you have a basal tumor. Progesterone receptor level is somewhat more informative in that it is rarely above 50%, but you can see quite a few are positive. And then on the right, the reiteration of the PCR data comparing to true triple negatives with a PCR rate of 37% versus an estrogen receptor positive basal PCR rate of 34%. This is in comparison now to the luminal tumors where the rate of PCR is significantly lower. Now, an interesting and important aspect of this research that we have performed using MammaPrint BluePrint is to look at the distribution of MammaPrint and BluePrint categorization in white women with hormone-positive breast cancer versus Black women with hormone-positive breast cancer. And these are data from a collaboration we have undertaken with Dr. Sonia Reed and Dr. Tuya Pal at the Vanderbilt University Medical Center in association with our FLEX study. And in this case, you can see the relative proportions of luminal B, hormone-positive basal, and true triple-negative basal. I'll call your attention to the middle columns where the solid bar are Black women, the hatched bar are white women, and the important finding is that this entity, estrogen receptor positive basal breast cancer, appears to occur twice as frequently in Black women as it does in white women. In other words, even within the hormone positive population of Black women, there is a higher rate of more aggressive biology. And we have considered that it is likely that the well-known poorer outcomes for Black women with breast cancer, although due to many factors that are social determinants of health outcomes, some of these poor outcomes may be due in part to undertreatment of this entity of ER-positive basal breast cancer if it is not recognized. And as you can see here, it really requires gene expression profiling to recognize this subtype. So with that, Dr. Alberty will return to the case, and we can walk through the subsequent management.
Yeah, so I was about to say, obviously, I felt very confident based on the genomic results to send this patient for evaluation for neoadjuvant chemotherapy. Before we did that, however, we obviously did extent of disease imaging via PET scan, which thankfully was negative for systemic disease. She also had genetic panel testing. She was a very young woman, obviously under 50 years old. Nowadays, we are testing more and more women, and obviously that's for another conversation, but she did have genetic panel testing, which was negative. Like I mentioned, she was referred to medical oncology, and my medical oncology colleagues saw her and recommended neoadjuvant dose dense ACT. During her course, usually what I do as a surgeon, I see them halfway through their treatment, mostly just to assess response to treatment, both in the breast and the axilla, understanding that particularly in the axilla, if they have a clinical downstaging where they go from palpable to non-palpable, then they would fit the criteria to attempt a sentinel node biopsy and a targeted axillary dissection. And so at the end of her treatment, she had proven to have an excellent clinical and radiologic response, and I could no longer feel a mass, any mass, whether in the breast or in the lymph node. So in terms of surgery, after she finished her neoadjuvant chemotherapy course, we spoke about surgery. She would have been a candidate for lumpectomy and axillary staging. In this particular case, the patient chose to undergo bilateral mastectomy and immediate reconstruction. And then on the ipsilateral on the left side, we also did a sentinel node biopsy with targeted axillary dissection. And for these cases where they present with a palpable node that has been pathologically proven to harbor cancer, then those patients, I usually will do a targeted axillary dissection. On the right here, you can see a mammogram image on the day that she was localized, that lymph node was localized. And so you can see localizing seed right next to the lymph node that was clipped and biopsied. Those patients, intraoperatively, I will have a frozen section assessment of that lymph node. And in the setting of no cancer, then we leave it at that and we don't do a completion axillary dissection. Next slide.
Yeah, very good. I just wanted to ask, clearly the option of using targeted axillary dissection, clipping the node as you've done here, with neoadjuvant therapy, the possibility of doing targeted axillary dissection and avoiding an axillary lymph node dissection must depend on what your expectation is of getting a pathologic complete response and downstaging the axilla to the point where you could avoid an axillary node dissection. It's clear that with HER2 positive and triple negative breast cancers, the observed likelihood of pathologic complete response is high enough to routinely apply this. But when do you choose to apply targeted axillary dissection in a hormone positive HER2 negative patient?
Yeah, well, so if you look at the surgical oncology data, like our data, right? The big study in the U.S. was Alliance 1071, and so in patients that, again, like I mentioned before, that are clinically positive, that are pathologically proven to have lymph nodes that have cancer, after they receive their neoadjuvant therapy, if they have what we call clinical downstaging or they become non-palpable, then those patients, you can offer this alternative surgical option, understanding, like you said, obviously triple negative and HER2 cancers downstage at much higher percentages than ER positive tumors. But again, when I look at the genomics of this particular tumor with a PCR rate of 34%, then you feel as a surgeon much more comfortable in doing this. And again, we remember that we do frozen sections, so intraoperative assessment of the node in these cases. And so again, there's a sort of a histologic check to make sure that we proceed with the correct surgical therapy.
Very good. So here is the results of the pathology. If you could go over that with us.
Yeah, so this is part of her pathology. Obviously, it's not her complete report, but you can see here on the left, first of all, one of their lymph nodes, she actually had 3 lymph nodes, 3 specimens, and she had a total of, I believe, 7 lymph nodes, and they were all negative for disease. Important to note that there was some treatment effect identified. So clearly there was some cancer there. The chemotherapy did its job, and you could see that histologically. And then section E, or in the bottom of the left side, you can see that in the total mastectomy specimen, there was no residual carcinoma. And again, they were able to see pathologic evidence of treatment. And so this patient did achieve a pathologic complete response. And as a surgeon, obviously, we're very confident in being able to avoid an axillary lymph node dissection and its possible comorbidities in these cases.
Yeah, and wonderful outcome for this young woman. So she's had her neoadjuvant chemotherapy, dose-dense ACT, with an excellent response. She is hormone receptor positive by routine immunohistochemistry, so endocrine therapy would still be part of the standard of care. Which endocrine therapy was chosen for this patient?
Yeah, so for this patient, initially my medical oncology colleagues, again, she's premenopausal. I believe they had checked her hormone levels just to make sure. She was premenopausal, and they initially offered tamoxifen, which I believe she started taking. And then eventually they switched her to an AI with ovarian suppression. They also offered, I don't know if that's the next slide, it is, but they also offered the CDK4/6 inhibitor as well. And so currently this patient is on abemaciclib and an aromatase inhibitor with ovarian suppression.
Yeah. So again, very interesting course of therapy. So she achieved a pathologic complete response with chemotherapy alone. Although she's hormone receptor positive, she's genomically basal, which by definition is a subtype defined genomically by Blueprint, which does not appear to have intact estrogen receptor signaling. Now, I will tell you that we do not have data with the estrogen positive Blueprint basal breast cancers for withholding endocrine therapy, although biologically one would question how beneficial it will be. And in this particular case, this young woman is getting fairly aggressive anti-estrogen therapy. The other addition, which is also part now of the standard of care, is the addition of CDK4/6 inhibitor therapy. We have very little data regarding how helpful or necessary this is in the case of women who have achieved a PCR from neoadjuvant chemotherapy. We know that it improved long-term outcomes in high-risk hormone-positive breast cancer. But again, what we need to do in the near future is to reconcile these standard of care approaches with what we learn now from comprehensive gene expression profiling. I want to also share, however, that from that same clinical trial I reviewed earlier, the NBreast trial, we not only had PCR rates, but we also have 5-year outcomes, in this case, overall survival. And we did show that estrogen receptor positive Blueprint basal breast cancers shown in the red lines here will benefit greatly in terms of their long-term outcomes from achieving a PCR to a neoadjuvant chemotherapy. As you can see in the solid line, over 82% survival at 5 years with a very aggressive node-positive patient in this case. And then, of course, if a PCR is not achieved, as shown in the dotted red line, those outcomes are similar to triple-negative breast cancers that we've already seen, where the survival at 5 years is less than 60%. That would constitute probably the worst outcomes for hormone-positive breast cancer. And so it emphasizes the importance of knowing whether you're dealing with a basal, a genomically basal hormone-positive cancer. In fact, one of the questions that have been appropriately raised is, with the genomics and biology of this subtype of estrogen-positive cancer so similar to triple-negative, should they be considered for additional aspects of triple-negative therapy? For example, if they don't achieve a PCR, is capecitabine appropriate? And what about immunotherapy? Both therapies having now been approved in triple-negative breast cancer, capecitabine in particular for those cancers that don't achieve a PCR. Now, I want to close on this case because she had a wonderful outcome by pointing something out which is now in the realm of research, and that is that you can see here her MammaPrint result was at the highest end of the high-risk category, which, as I mentioned earlier, would be called now high 2 on the report. And high 2 is quite interesting, primarily because of data generated by the I-SPY neoadjuvant trial, in which they use MammaPrint high risk as an enrollment requirement for hormone-positive breast cancer in their neoadjuvant study. And what they have observed in multiple phase 2 trials is that MammaPrint high-2 patients that are estrogen positive have increased sensitivity to a variety of agents that are not typically used in estrogen positive breast cancer, including, most importantly, immune checkpoint inhibitors. In fact, the sensitivity observed in I-SPY was of such significance that this has now led to a Southwest Oncology Group prospective randomized phase 3 study of immunotherapy as neoadjuvant treatment in hormone-positive breast cancer, with the principal investigator for this trial being Dr. Aaron Cobain from the University of Michigan. The enrollment criteria for this study, again being a neoadjuvant trial, is clinical stage 2 or 3 hormone receptor positive HER2 negative breast cancer, but also now for the first time, the integration of a gene expression profile to identify patients who may benefit. In this case, patients need to have a MammaPrint high risk 2, as this patient did, on core needle biopsy. And then patients will be randomized 1-to-1, 960 such patients, to either standard ACT neoadjuvant chemotherapy or ACT plus the PD-L1 inhibitor durvalumab. They then go on to surgery, radiation, and abemaciclib if selected, just as your patient did, Dr. Alberty, and then 10 years of follow-up. The primary endpoint, of course, is breast cancer event-free survival, but we will also, of course, see pathologic complete response rates and residual cancer burden. So although this trial was not available for this patient when she was diagnosed and treated, she did extraordinarily well with chemotherapy alone. So with that, let's move on to the second case.
Yeah, so we'll present the second case a little bit different than the first case, in that this was an image-detected cancer. So this case is a 62-year-old postmenopausal female, self-identified as Black. She was of Jamaican heritage or ancestry. And so she came in for her regular mammogram. She does it every year. And this year they did find a 7mm mass seen on her imaging. She did have no clinical complaints, so this was a true find on screening by our radiology colleagues. And so what they had found was an asymmetry on mammogram, and then there was a correlate on ultrasound, which you can see here on the right side, measuring 7mm, so sub-centimeter, still pretty small finding from the radiology side. The next slide. And so because this was an image detected finding, she underwent an image guided biopsy, and that pathology came back with an invasive ductal carcinoma, which was grade 2. It was strongly ER positive at 95%, but interestingly, she was PR negative, and then HER2 was negative as well. Like I mentioned before, I usually will test almost 100% of our patients. So she had a panel test that was negative for any pathogenic mutations. And then we, in a small, stage 1 cancer, surgery is usually the first step. And so we offered the whole breadth of surgical options, and the patient chose breast conserving surgery. We also spoke about axillary staging via sentinel node biopsy. And again, here on the right, you can see a specimen imaging. I do use wireless or a seed localization option. You can see the biopsy clip right on top of that. And so the pathology report here on your left notes one lymph node that was negative for carcinoma. And then in the breast, what was found was an invasive ductal carcinoma, which was 1.4 centimeters, a little bit larger than what we had seen on imaging, but still solidly a T1 tumor with a histologic score of 69, which would be a grade 2. There was also a little bit of ductal carcinoma in situ, and thankfully all of the margins were negative, so she did not need any additional surgery.
So you have a patient who is surgically staged now, stage 1, T1C N0. What is your next step and what additional information would be helpful now?
Yeah, so as with the other patient, I am a firm believer in genomics, and actually we do usually do genomics on core biopsy, but in this case, in the same way that I needed the information before, it's interesting to sort of understand how the tumors are behaving biologically. And so we did send the MammaPrint and BluePrint just to sort of understand the genomics of the tumor as well. And I believe the next slide, you can see the report, much like the other one, a little bit different, but this one being a luminal A type low risk cancer as per MammaPrint.
And her MammaPrint index is 0.355, which, again, going back to the categorization that is provided for all low risk, she is right at that upper border of low risk between low and ultra low at that 0.355, where we begin to call ultra low at greater than 0.355. Now, let me step in and mention that because she is low risk, it is clear that there is no benefit from chemotherapy for this postmenopausal woman with early stage breast cancer and a genomic low risk result by MammaPrint. But what about endocrine therapy management? Because those two categories, ultra low and low, have somewhat different implications, and she's right at the borderline. So ultra low risk is categorized for postmenopausal women by suggesting that such women may actually do well with less than 5 years of endocrine therapy, while for low risk that are not ultra low, there's also evidence that they may benefit from more than 5 years of endocrine therapy, extended endocrine therapy, in other words. And I think it's worthwhile to simply touch upon these two outcomes and the data behind them, because she is right in the middle. So talking about ultra low, again, from 0.356 in the positive range and upwards, I'd like to just touch upon two studies that help us understand the biology that's defined by ultra low MammaPrint. The first is this study, which was published in JAMA Oncology, first author Dr. Laura Esserman and colleagues from Stockholm. This was an important study looking at postmenopausal women from the Stockholm Tamoxifen 3 trial, a trial that was conducted in the late 70s and early 1980s, at a time when investigators were still trying to determine whether postmenopausal women with hormone-positive breast cancer needed additional therapy other than surgery. 652 such women with hormone-positive breast cancer were randomized after surgery to receive the standard of care at the time, which was no further therapy, or 2 years of tamoxifen, which, if at the end of those 2 years there had been no events and tolerance of therapy, women could continue for an additional 3 years. The value of this study, and the reason that it was such an important piece of data, was that there were 20 years of follow-up and all tumor blocks were available. Out of this analysis, we were able to extract mRNA and determine that MammaPrint was ultra low in 15% of this cohort. And here we have the 20-year results from this STO trial, showing that MammaPrint ultra low risk postmenopausal women had an excellent outcome with little or no endocrine therapy. You can see the group that received either 2 or 5 years of tamoxifen in the solid green line, and the group that received no therapy other than surgery in the dotted green line. You can see also that at 10 years, both groups are at approximately 100% breast cancer specific survival. And out to 20 years, the treated group, 97%, the untreated group, 94%, 20-year breast cancer specific survival, a really extraordinarily good outcome, indicating that there are indeed postmenopausal women who, with gene expression profiling with MammaPrint, if they are found to be ultra low, may not require a full 5 years of endocrine therapy. And I would add that while 5 years is certainly the standard of care, and in my time as the director of the Breast Cancer Risk Reduction Program, I was and continue to be an advocate of the chemopreventive benefit of anti-estrogen therapy for women with any stage of breast cancer that's estrogen positive. I would certainly advise that such women, even if they're ultra low, be recommended to receive 5 years if they can tolerate it. But in the face of significant toxicity and the wish to discontinue early, a woman who is ultra low may actually be able to safely discontinue therapy based upon these data. Now, this is one study, and we've actually published 4 such studies, including this study that I'm highlighting, which was published in the Journal of Clinical Oncology in 2022, looking at the large prospective randomized MIND-ACT trial, which enrolled nearly 7,000 women. And in this particular analysis, we looked at the frequency of ultra low risk and found 1,000 women in this trial with ultra low risk MammaPrint. What we were able to show now in a modern study with prospective randomization and enrollment was that that same endpoint, breast cancer specific survival, was greater than 99% at 8 years for women, whether they were either clinically low or clinically high risk, if they were ultra low by MammaPrint, a further confirmation of those initial STO data. And I'm pleased to say that as a result of these data and the other 2 publications to which I referred, the NCCN guidelines now recognize MammaPrint ultra low as an identifiable genomic subtype of hormone-positive breast cancer. Now, the other side here, where this patient actually falls, is low risk that is not ultra low, which you can see goes from just above 0 to 0.355 in the positive range, just where she is at that upper limit. And for this, I'm going to highlight one study primarily, although there are 2 major studies that have shown the same results. The first I'll mention, of course, is the NSABP B42 study, which looked at the benefit of extended endocrine therapy in a cohort of postmenopausal women with stage 1, 2, or 3A invasive breast cancer. As you may recall from this large seminal study, women had to be disease-free after 5 years of endocrine therapy. And then at the time of enrollment, they were randomized to receive another 5 years, in this case of an aromatase inhibitor, letrozole, or placebo. Now, if you follow the results of this trial, it was a positive study with a disease-free survival benefit in the letrozole arm of 3.3%. A real result, but not a very large benefit for the overall group without any further stratification. So the question certainly was raised, can genomics identify who benefits from extended endocrine therapy? And indeed, we applied MammaPrint in a study that was presented in an oral plenary session by Dr. Priya Rastogi at ASCO in 2021, and is now in a manuscript form soon to be published. The results are shown here, which shows that of these NSABP B42 patients, looking at the endpoint of disease-free survival, those that were MammaPrint MammaPrint low had a very significant disease-free survival benefit, not 3.3%, but actually 7.8%, with a significant p-value. In contrast to MammaPrint high risk, which showed no benefit from extended endocrine therapy. So with genomic profiling, we were able to take this cohort from B42 and identify the true group that would benefit. A similar finding with a different endpoint, breast cancer-free interval, 7% benefit. Now, with that ultra low subtype in mind from MammaPrint, we asked what proportion of these patients that are low are either ultra low or the remaining low. And we did that further exploratory analysis shown here, with UL being ultra low and LNUL being the low risk that is not ultra low. And here, with this further genomic stratification, we find that the benefit of extended endocrine therapy is limited to that group, now with a 9.5% benefit in disease-free survival and a 7.9% benefit in breast cancer-free interval. A very similar result was shown with the second study, which I won't have time to mention, the IDEAL trial, which compared 7.5 years to 10 and showed the same thing, that MammaPrint low risk that was not ultra low was the only group showing a significant benefit to extended endocrine therapy, even when comparing 7.5 to 10. Here's a graphic representation of that B42 finding, which shows how with gene expression profiling with MammaPrint, we can actually identify the true group benefiting from extended endocrine therapy. Now, we know from B42, as well as from other extended endocrine therapy trials, such as MA17, that the risk of a late recurrence between years 5 and 10 is increased in women with higher clinical risk, larger tumors, positive nodes. But simply having an increased risk of late recurrence does not prove that those women will actually benefit from extended endocrine therapy, that those late recurrences are actually preventable. So what we've shown is that MammaPrint low risk that is not ultra low identifies preventable late recurrences with extended endocrine therapy. Now, one other point I think that is important to make because of our topic this week is, again, the genomics of breast cancer as it relates to racial disparities, because clearly the question has been, the issue has been observed that Black women in general have been underrepresented in the clinical trials that have developed our standard of care, and they've been underrepresented in the development of gene expression profiles. So it is reasonable to ask, do genomic assays that were developed primarily in a population of white women apply to Black women? This question has been applied to all the genomic assays that are now in use in Black women. And so for MammaPrint, we sought to try to answer this question. And I'm going to share with you data that was recently presented at the most recent San Antonio Breast Cancer Symposium. Again, our collaboration with Dr. Sonia Reed and her colleagues at Vanderbilt, where we further analyzed her cohort from a study that was enrolled in Vanderbilt, referred to as the BEST study. This was a group of Black women with estrogen receptor positive breast cancer for whom Vanderbilt and Dr. Reed and her colleagues had 10 years of follow-up. So we took that cohort and we applied MammaPrint and BluePrint to determine how MammaPrint performed in terms of predicting long-term outcomes of these Black women. And those results that we presented at San Antonio are shown here. You've got relapse-free survival on the left and overall survival on the right. And the important group to look at are the low-risk women in the light blue, luminal A and low risk by MammaPrint, just as this patient that we're discussing today would be. And you can see that for relapse-free survival out to 10 years, that outcome is 97.7% relapse-free survival. And then on the right, that same group 100% overall survival, indicating that at least in this cohort, Black women who are stratified as low risk by MammaPrint do very well. In fact, they do just as well as white women with the same low risk result, meaning that there is no evidence that MammaPrint has different results or different outcomes for Black versus white women, particularly if they are called low risk. Now back to your patient, Dr. Alberty, to finish. She's had her surgery. Obviously, she's estrogen receptor positive. And so the standard of care for her would be radiation therapy and endocrine therapy. Standard of care, of course, would be for 5 years. She is not technically ultra low, although she's right there on the border. And as far as low risk and extended endocrine therapy, she's got clinically low risk disease. So the magnitude of benefit of extended endocrine therapy, I would say, while positive, may not be very large. Is this the therapy plan that is being undertaken with this patient?
Yeah, for sure. So obviously after her surgery, she did not need any additional surgery. All the margins and the lymph nodes were negative. So she was referred to radiation therapy, and she did receive whole breast radiation in the adjuvant setting. And she did see our medical oncology colleagues who agreed no chemotherapy was needed in this particular case. And she was offered, she's currently on an AI for at least 5 years. And obviously, I imagine, that's a decision that can be taken again in the future.
Yeah. So another, I think, really illustrative case, particularly when it comes to thinking about her endocrine management. I want to kind of close this session by referencing another clinical trial besides the trial I mentioned earlier with the Southwest Oncology Group. And that is the so-called DEBRA trial, for which this patient would also have been appropriate had this been available to her at the time. And this is de-escalation of breast radiation. So this is a trial being undertaken by the NRG, in which women with T1N0 hormone-positive breast cancer between the ages of 50 and 70, who also have a low-risk genomic score. In this case, MammaPrint low risk is an acceptable enrollment criterion. These women are then randomized to standard of care as your patient received breast irradiation with endocrine therapy, or in the experimental arm, withholding breast radiation and relying entirely on endocrine therapy. Clearly, if this patient were to have enrolled in this trial, despite being close to the margin of ultra low, had she been randomized to the no radiation arm, she really would have been committed to a full 5 years of endocrine therapy. So with that, we are just about at the end of the hour. I want to thank you all for your participation. And Karen, I am not sure if we have time for questions, but we've got another couple of minutes, and I and Dr. Alberty, I'm sure, would be happy to take questions if you have.
Yes, we do have one question that came in that we could address, and this was probably geared towards you, Dr. Alberty. The question was, were your med-oncs open to neoadjuvant chemo? This particular attendee said that they're getting pushback from their medical oncologist to order this test. So how have you navigated that?
Yeah, so in this particular case, so like Dr. Audeh mentioned before, she did have a positive note. And so those patients, we always think about the possibility of some form of a preoperative treatment to try and achieve that, elusive downstaging in the axilla. So this is a patient that would definitely get referred to medical oncology for evaluation for any, preoperative treatment. In her particular case, obviously, the genomics are showing that she is behaving in a basal type of way. And so those patients, we know that respond very well to chemotherapy. And so to answer your question, there was no pushback. And like I mentioned before, usually I will get these, the MammaPrint BluePrint assay on the core biopsy. So I have that information from the get-go when we are deciding a patient's treatment outcome going forward. And so, no, there was no pushback in that particular case. I had the sort of the fallback, and that she did have a positive note, and I know other places will attempt to downstage and and we'll talk about this in a subsequent webinar where we're really trying to pick which patients would benefit the most from which particular types of preoperative therapy. And so in this particular case, I was comfortable that you would have a great response to the treatment.
Yeah, I'd like to chime in. Thank you for that explanation, Dr. Alberty. As you mentioned, our next webinar in the series will actually focus on the use of gene expression profiling with MammaPrint and BluePrint to guide decision-making regarding selection of patients that are hormone positive for neoadjuvant therapy. Because there has been the question, of course, for many years as to whether pathologic complete response, for example, is a useful endpoint in estrogen receptor positive breast cancer. And also, with the overall relatively low likelihood of significant downstaging with chemotherapy in a hormone-sensitive tumor, how gene expression profiling information can help further stratify patients into those with a significant likelihood of PCR versus those with a very low likelihood. I'd also like to add on one point that's also been a question I've heard many times, which is the reliability of core biopsy with genomics. And we have published concordance data between MammaPrint and BluePrint performed on a core biopsy compared to the same testing performed on the same tumor, but at the time of resection, showing a greater than 90% concordance in the results, very similar to the same level of concordance we see with IHC and actually better than FISH. So relying on the core for gene expression profiling is well documented and well established. And of course, the I-SPY trial has been doing it for a decade.
All right, thank you both for your answers there. So we are at time, so this concludes today's webinar. In the chat, I did put the information and links for the next two upcoming webinars on March 26th, so in about 2 weeks or a week and a half, and then April 1st. And in addition, if you plan to attend ASBRS, we will be having a Friday evening symposium with Dr. Audeh and Dr. Alberty. So if you're there, we'd love to have you register, and the link is in the chat. So with that, we'll conclude, and thank you for joining today.